Hello, good morning, good afternoon, or good evening, wherever you join this webinar from ESGE in collaboration with KSGE. My name is Helmut Messmann. I'm the past president of the ESGE, and it's a great honor that we continue now our collaboration of webinars with our Korean friends. I think it's a third webinar we have planned together, and great thank you to Professor Byeon. He will co-chair this session with me. He is the current General Secretary. This is correct?
Yeah.
Yeah.
Right.
And yeah, today we have I think a very interesting topic about gastrointestinal subepithelial lesions. And I think in Europe and also in Asia, it's a lot of experiences in this field in the diagnosis and in the treatment. And the plan is for this event that we have two lectures, one about how to diagnose lesion, and then in the second, the therapy of a subepithelial tumor. And this will be presented then from our colleagues and friends in Korea. But for now, I think we can start with the two lectures, Professor Byeon. Any words from your side? I mean, I'm happy that we have more than 1,000 registered participants, and the majority definitely comes from Asia, from Korea, and this is really great. And you have the chance to see all of this as a pre-recorded webinar later on both websites. So if you have any friends who cannot join today, you can recommend to join us later. Yeah. So for the moment, I think this we can start straightforward, and can introduce our first speaker. It's Professor Facciorusso. Sorry, and Antonio. Your forename is much easier to pronounce. He is actually associate professor at the University of Foggia. He has graduated in Milan and completed his residency program in gastroenterology at the University in Bari. Was at the National Cancer Institute in Milan, and as said, he is now associate professor in Foggia, and is an outstanding expert in interventional endoscopy and also in hepато-oncology. So he's also a very active member for our society in the ESGE, and is part of the guidelines committee. And I think you're really very grateful that you are so active for ESGE and took over this presentation. And we are now all very interested, Antonio. And yeah, the floor is now yours. You can present now your lecture about 20 minutes, I would say, and then we continue with the second part and have at the end a panel discussion. So please, Antonio.
Thank you. Thank you, the organizer, for the kind invitation. My topic will be on the diagnostic approach to gastrointestinal subepithelial lesions. Subepithelial lesions represent a common finding in routine upper GI endoscopy. We are talking about upper GI because most of the lesions are found in upper GI. Lower GI subepithelial lesions are very uncommon. Most subepithelial lesions are asymptomatic, so they are detected incidentally on endoscopy performed for unrelated reasons. Symptomatic cases are not frequent. They are mainly characterized by iron deficiency anemia, less frequently over GI bleeding, even much less frequently abdominal pain due to huge masses that determine intestinal obstruction. The endoscopic aspect is characterized by small, frequently less than 2 centimeter rounded protuberances with normal overlying mucosa. This is the main characteristics, main features of most subepithelial lesions, the normal overlying epithelium. Some lesions may present with a central depression or umbilication, like in this case, for example, quite characteristics for ectopic pancreas. Features suspicious for malignancy are large lesion size, growth during the follow-up, and presence of ulceration. This is a quick overview on the main kinds of subepithelial lesion that we can find in the upper GI. The most important are the GIST, gastrointestinal stromal tumor, mainly in the stomach, originating from the interstitial cells of Cajal, so in the muscular layers of the GI wall. So the second layer, the muscularis mucosa of the mucosa, and particularly from the fourth layer, the muscularis propria. Then we have the leiomyoma, again from the second or fourth layer. We will see some difference in the endoscopic and ultrasound characteristics imaging of these lesions. Less frequent other kinds of lesions. We already mentioned the ectopic pancreas, for example. Endoscopic ultrasound plays a fundamental role in the diagnostic algorithm of these lesions. How appears the GI wall at endoscopic ultrasound? We have 5 layers. One, the inner layer, hyperechoic. It's not a real layer, it's the interface between lumen and mucosa. The second layer, hypoechoic, represents the mucosa itself. Third layer, hyperechoic, the submucosa, for example, NET, neuroendocrine tumors sometimes originate from there. Fourth layer, hypoechoic, muscularis propria. Fifth layer is the adventitia. So endoscopic ultrasound is recommended as the best tool to characterize subepithelial lesions. The accuracy for the originating layer is up to 80%, but you can see a pretty wide range because, you know, endoscopic ultrasound is a highly operator-dependent technique. Accuracy for lesion size is higher, up to 90%. Some features at endoscopic ultrasound are pathognomonic for lipoma or varices. But I think the most important strength of endoscopic ultrasound in this setting is the ability to get a tissue sample for histological diagnosis. So when tissue is required, so when biopsy is required, according to European guidelines released last year, it's required for subepithelial lesions highly suggestive for GIST, in particular if they are more than 2 centimeters and in presence of high-risk stigmata, the aforementioned ulceration, growth during follow-up. So when we have suspicion for malignancy. But you can see weak recommendation, very low quality evidence. So we need further studies to inform the clinical practice. I think we have some fair difference, and I would like to get during the discussion the opinion of our Korean friends about that. Some fair differences between the Asian guidelines and some Western guidelines. In fact, according to Asian guidelines, surgical resection is indicated for GIST even smaller than 2 centimeters, so biopsy is required in all cases suspected for GIST, even for small lesions. According to many Western guidelines, for example, the NCCN, National Cancer Comprehensive Network guidelines, smaller GIST, smaller than 2 centimeters, may be just followed up by endoscopic ultrasound, of course, in absence of high-risk stigmata. So in this case, no biopsy is required. This is what I do usually in my clinical practice. When I have a small lesion without evidence of high-risk stigmata, ulceration, growth during follow-up, I keep the lesion in follow-up. I don't biopsy immediately. But of course, I'm open to discussion for that. Which are the quality indicators for tissue acquisition for endoscopic ultrasound? At least 85% for sensitivity, accuracy for malignancy. This is true for pancreatic masses, but this data can be easily translated also to other kinds of lesions, including subepithelial lesions. This is an overview of the timeline of several needles for FNA, then for FMB developed and introduced in the clinical practice over the decades. In the last years, we have the highly performing newer end-cutting needles. So FMB needles with end-cutting tip that are able to grasp the lesion and to get high-quality samples. So, for example, the Francine needle, the fork tip needles. But we have also other kinds of needles, sorry. So methods for US-guided tissue acquisition. We have FNA, FNB. If in the case of pancreatic masses, FNA may still have a role if we have the availability of rows, the cytologists in the endoscopic room. In the case of subepithelial lesion, data evidence is all in favor of FNB. So FNB should be absolutely preferred. Okay. We know the limitation of FNA, low cellularity, able to provide only cytological diagnosis, tissue structure not preserved, difficulty to obtain high-quality samples useful also for molecular profiling, personalized medicine, immunohistochemistry, all things that are very important for the oncologist nowadays. And prolongation of procedural time, because frequently we need more needle passes with FNA to get adequate samples. Again, an overview of main FNB needle, the older reverse bevel needle, and now we have the end cutting needle. This is a very nice study from the Orlando group. They review their huge retrospective series of lesion, any kinds of lesion sample with FNA and FNB. The title is quite explicative. In memoriam, so death of fine needle aspiration, birth, fine needle biopsy. So fine needle biopsy is significantly superior as compared to FNA for all kinds of lesions, including subepithelial lesion, when we want a better diagnosis. In this case, we're talking about cytology on cell block. If we want just the adequacy, in presence of rows, there is not a significant difference, but as you can see, there is a trend still in favor of FNB. But this is in presence of rows. So when we have the cytologist in the room, for example, in my center and in many other Italian centers, we don't have this opportunity. So we already talked about the potential improvement with FNB, and including the possibility to obviate to the need of the cytologist in room. If we use FNB needle, we don't need the cytologist in the endoscopic room. So what do the guidelines say? Of course, I will give you the European perspective, so I will mention frequently the European guidelines. ESGE recommends use-guided FNB or mucosal incision-assisted biopsy. We will talk later about it. These are more difficult techniques based on advanced resection techniques. So a more difficult diagnosis, but in expert hand, it's absolutely effective and safe. Equally for tissue diagnosis of lesions more than 2 centimeters. And we are sure about this statement. Strong recommendation, moderate quality of evidence. But if we switch to smaller lesion, less than 2 centimeters, ESGE suggests, this is only a suggestion, weak recommendation, low quality evidence, so not a true recommendation, a suggestion, the use of mucosal incision-assisted biopsy as first choice with FNB as second choice. But we will see better this aspect. This is a meta-analysis we published some years ago comparing FNB versus FNA for subepithelial lesions. FNB clearly overperformed FNA for this lesion with a pooled adequacy rate up to 95%, so very, very, very high. This is a more recent retrospective study, multi-center retrospective study conducted with a propensity score matching, comparing use FNB versus bite-on-bite biopsy. Bite-on-bite means removal of the overlying epithelium through some samples, through some biopsy, and then try to biopsy directly the subepithelial lesions. Of course, no point in doing the bite-on-bite with the standard forceps. So if we do it, we should do at least with the jumbo, the larger forceps. In this study, we found that FNB clearly overperformed bite-on-bite for all kinds of lesions and for all diagnostic outcomes, and even for safety, because the risk with bite-on-bite biopsy due to the multiple biopsies is the risk of bleeding, sometimes even severe bleeding, serious bleeding. So FNB was clearly superior for all safety and diagnostic outcomes as compared to bite-on-bite biopsy. And this was true for any kind of subgroups. This is a network meta-analysis we published a couple of months ago, so very recent in endoscopy. A network meta-analysis based on 8 trials comparing overall all the main diagnostic approach to get samples for subepithelial lesion: bite-on-bite biopsy, mucosal incision-assisted biopsy, FNA, FNB. We found that FNB and mucosal incision-assisted biopsy provide high performance and are significantly superior, so they should be preferred to the other techniques. Which are the main findings of our work? Bite-on-bite biopsy techniques shows a poor diagnostic performance, so it should be abandoned. FNB is superior over FNA, in particular for larger lesion, but we should consider that, okay, we found that FNA may still be competitive when ROSE is available, and we found that for smaller lesion, mucosal incision-assisted biopsy is the best technique, but we should specify that these trials use mainly older FNB needles, so the reverse bevel needle. We expect better results with newer end cutting needles. Now I'm the principal investigator of a multi-center trial comparing reverse bevel FNB needle versus Francine reverse needle in the setting, specifically in the setting of subepithelial lesion. So we will publish our results soon. We will see. I expect that results with FNB will be better with newer needles. The role of contrast enhancement during endoscopic ultrasound. The ancillary technique may be useful, in particular contrast enhancement. We have still insufficient evidence for elastography, but they cannot replace, absolutely, they cannot replace tissue acquisition when needed. So contrast enhancement can be useful for the characterization of some subepithelial lesions. For example, this is a GIST with high enhancement. This is a leiomyoma with low enhancement. So the lesion can have the same characteristics as endoscopic ultrasound. They may originate from the same layer, mucosal layer, GI wall layer, but this is a big difference that is very useful for the differential diagnosis. But still, if we need biopsy, we cannot replace biopsy with contrast enhancement. This is a very nice study from Korea, published some years ago in Gastrointestinal Endoscopy about elastography. The author correlated this semi-quantitative value, strain ratio, the value of strain ratio with some specific kind of lesion, but this data need further validation. Artificial intelligence, sure, is the future, but we don't have enough data. We have very few data in endoscopic ultrasound in general, unlike, for example, colonoscopy or other things. Most of these data are about pancreatic masses. To the best of my knowledge, this is the only study from Japan about use of artificial intelligence for subepithelial lesions. So we need further data. I will not talk very deeply about mucosal incision-assisted biopsy because I'm sure our Korean friend that is a master of this technique will explain very, very carefully all the advanced resection techniques. And on those advanced resection techniques are based this diagnostic approach, the mucosal incision-assisted biopsy. So newer techniques involve the unroofing of subepithelial lesion to expose the surface and then to get the biopsy directly from the subepithelial lesions. These are some meta-analyses published by the group of Dag Adler, in Annals of Gastroenterology. In expert hands, these techniques are absolutely safe and effective. More than 90, even up to 95% accuracy, diagnostic yield, bleeding not frequent, and no cases of very low number of cases of severe bleeding, no case of perforation. This is another meta-analysis about single incision with needle knife, again by the group of Adler, published some months ago in Gastrointestinal Endoscopy. Again, adverse event rate 7.5%, mainly bleeding, but no case of severe bleeding. So these techniques are effective and are safe in expert hands. The problem is, where are these expert hands? Probably in Asia, these expert hands are very, very common. In Europe, of course, we have many centers with huge expertise in these advanced resection techniques. In my center, for example, we don't have this huge expertise, but still, in my experience, in my center, but also in other important Italian centers, even with good expertise in advanced resection techniques that I visited, the gold standard for the technique for the diagnostic approach to subepithelial lesion is endoscopic ultrasound fine needle biopsy. But of course, I'm glad to listen to the other members of the panel opinion. Surveillance, again, I will give you the European perspective based, this is important, on weak recommendations. So these are only suggestions. We need studies, absolutely. In the case of gastric lesions with no definitive diagnosis, okay, we may keep these lesions if they are small, less than 2 centimeters, in strict follow-up, okay, with just gastroscopy. So the first characterization is with endoscopic ultrasound, then the follow-up just with the gastroscopy, and we see if there are some high-risk stigmata occurring during the follow-up or growth of the lesion during the follow-up. Of course, the schedule of the surveillance is stricter at the beginning, and then we can delay it. In the case of asymptomatic lesions more than 2 centimeters, when we decided not to resect the lesions, in this case, the surveillance should be done with both gastroscopy and endoscopic ultrasound. In the case of GIST less than 2 centimeters, we may perform either surveillance or resection, of course, provided that there are not high-risk stigmata. Again, weak recommendation. In my center, we do the surveillance, okay? But the case should be discussed in a multidisciplinary setting and also with the patient. Of course, if we have a young patient perfectly fit for surgery, okay, in this case, we may consider this option if the patient is willing to undergo surgery. Otherwise, okay, surveillance may be a valuable option. In the case of the uncommon non-gastric lesion, duodenal or lower GI lesion, in this case, the risk of malignancy is higher as compared to gastric lesions. So in this case, we should be more careful, maybe surgery, or if there is expertise, resection, endoscopy resection may be an option. I will not talk about the treatment. My colleague will talk about treatment. I just give the European perspective based on the guidelines. Again, weak recommendation, very low quality evidence. Okay, in the case of lesion GIST, gastric GIST less than 2 centimeters, in this case, we already talked about it. We discussed with the patient, we discussed in a multidisciplinary setting, but surveillance may be an option. In the case of larger lesions, okay, if we have expertise, endoscopic resection may be an option for gastric lesions up to 3.54 centimeters. In the case of larger lesions or non-gastric lesion, in this case, many Western guidelines suggest resection, although we have some interesting data, mainly from Asia, about safe and effective full-thickness resection also of duodenal lesions, for example. But I'm glad to listen to the other opinion. Thank you.
Yeah, thank you, Antonio, for this brilliant lecture. As said, we would like to discuss your talk after the talk from our next expert, and I hand over to Professor Byeon, please.
Okay, thank you, Antonio, and thank you, Professor Helmut Messmann. I'm Byeon, the Secretary General of KSGE. I'm very happy and honored to join this ESGE and KSGE joint webinar today. As Professor Messmann mentioned, it is the third ESGE-KSGE joint webinar. And today we have 2 lectures about upper GI subepithelial tumors. I think there can be mostly similarity between Europe and Asia for management of gastric subepithelial tumors, but there may be some differences between Europe and Asia. So after the 2 talks of today, we will have a Q&A discussion time, which must be very interesting. Okay, let me introduce the second speaker, Professor Gwang Ha Kim. He is the professor of Busan National University College of Medicine. He graduated Busan National University College of Medicine, and he is a very active endoscopist and especially upper GI specialist in Korea, and he is now the director of the publication committee of Korean Society of GI Endoscopy. And the title of his talk today is How to Approach and Treat Upper GI Subepithelial Tumors. So Professor Gwang Ha Kim, please.
Yeah, thank you for your kind introduction. Yeah, my name is Gwang Ha Kim from Busan National University. Today, I'll talk about how to approach and treat upper GI subepithelial tumors based on my personal experience. I'll talk about in near clinics how to treat the patients. Let me start. As you know, instead of subepithelial tumor, we usually use the term submucosal tumor. Due to increased check-up endoscopy, the incidence of subepithelial tumor has been increasing now. According to recent Korean youth study group data, the incidence of subepithelial tumor during upper endoscopy is reported to be 30.1%. It's not so rare. However, when we meet a subepithelial tumor in near clinic, we worry about whether it is benign or malignant. However, it is not so easy whether to resect the subepithelial tumor or not. I think it depends on four important issues, such as presence of symptoms, malignant potential of subepithelial tumors, patient aspect, and endoscopy aspect. I'll talk about each item in detail. First, presence of symptoms, including history. When a patient with subepithelial tumor has definite symptoms such as dysphagia, GI bleeding, or severe oral pain, the tumor should be resected, mainly by surgery. Second is malignant potential of subepithelial tumors. As you know, representative subepithelial tumors with definite malignancy are neuroendocrine tumor, intermediate high-risk GIST, mild lymphoma, esophageal carcinoma, and metastasis. Then, how can evaluate the malignant potential of subepithelial tumor in near clinics? We usually use endoscopy with or without biopsy, US guided tissue acquisition, US FMB, endoscopic resection, or parallel examination. Last year, I published about a review article on systematic endoscopic approach for diagnosing gastric subepithelial tumors in Korea. Please refer to it. Firstly, it is endoscopy. During endoscopy, what endoscopic features should we focus on in subepithelial tumors? We must check location, shape, color, surface, mobility, consistency, and size of subepithelial tumors. This slide showed the frequency of subepithelial tumors according to location. This is my data. In the case of gastric subepithelial tumors, leiomyoma usually located against cardia. GIST is usually located against body and fundus. Schwannoma usually located against body. Inflammatory film poly, lipoma, glomus tumor, ectopic pancreas are usually located against the antrum. In the case of duodenal subepithelial tumors, ectopic pancreas is usually located against the duodenal bulb. GIST and lipoma usually located during the second portion. Therefore, based on the location of the tumor, we can sometimes predict histopathology of subepithelial tumors. Next is color. Almost subepithelial tumor has a similar color to surrounding normal mucosa, like this. When the color is yellowish like this, the region may be lipoma, soft, very hard, glandular tumor. When the color is somewhat translucent like this, the region may be cyst region. When the color is bluish like this, the region may be a V malformation or varices. Then, during endoscopy, when should we perform endoscopy post-biopsy for subepithelial tumors? Generally, I do not recommend to perform endoscopy post-biopsy for all subepithelial tumors. For me, based on surface, mobility, and consistency of subepithelial tumors, I decide whether to perform endoscopy biopsy or not. As you know, almost subepithelial tumors has small surface like this. When we can see definite surface umbilication or deep opening like this in the stomach duodenum, the region may be ectopic pancreas. When we can see tiny opening like this on the surface of a subepithelial tumor, the region may be gastritis cystica profunda, ectopic pancreas, or Brunner gland hyperplasia. However, we can see definite surface erosion, retraction, and ulceration. We must consider the malignant potential. At this situation, I usually recommend endoscopy post-biopsy somewhat aggressively. To check the mobility and consistency of tumors, we usually use endoscopy photo like this. However, it is contraindicated to use endoscopy biopsy in suspicious vascular lesion like this due to bleeding risk. From now, I'll talk about study signs. When you find the subway tumor, we push the subway tumor from one side to the other side. The region is easily movable. We call rolling sign is present. When you compress the center of the tumor is easily compressible. We call pillow sign is positive. The clinical meaning of rolling sign is where the subepithelial tumor is mainly located in muscularis mucosa or deeper. Therefore, when a subepithelial tumor has definite ulceration fibrosis or have wide base improper muscle layer, rolling sign is also absent. Representative subepithelial tumor without rolling sign are inflammatory pulmonary polyp, neuroendocrine tumor, SH-like carcinoma, and so on. Next is the tenting sign. When we grasp the subepithelium by using endoscopic biopsy, the subepithelium easily separated from inner tumor, we call tenting sign is positive. The clinical meaning of tenting sign is similar to that of a rolling sign. Therefore, when a subepithelial tumor has a definite component in lamina propria mucosa or have ulceration or fibrosis, tenting sign is absent. Pillow sign is also called as a cushion sign. The clinical meaning of a pillow sign is the tumor has a definite liquid or lipid component. Therefore, this lesion can be diagnosed as a cyst lesion or lipoma. Previously, Professor Antonio talked about I usually use bite-on-bite technique for subepithelial tumors for obtaining tissue from subepithelial tumor. Like this, bite-on-bite technique is also called as digging biopsy techniques. It is reported the diagnosis yield of this technique is between 14 and 42%. However, there are several limitations such as too many biopsies by 10 times and increased bleeding risk about 30% like this. As I told you before, I do not recommend to perform endoscopic biopsy for all subepithelial tumors. In my case, when a definite erogenous ulceration presence and or rolling tenting sign is absent, I usually perform endoscopic biopsy by using bite-on-bite technique 3 or 4 times. This is my real policy for performing endoscopic biopsy for subepithelial tumors. Third, patient aspect. When doctors explain to patients, you don't worry about this subepithelial tumor because it looks benign. However, some patients have tremendous emotional burden, such as malignant change, increased size, and occurrence of complications on prior examination. Therefore, we sometimes resect the tumor by endoscopy or by surgery based on patient's strong need. Lastly, the endoscopy aspect. Endoscopy's competence and experience and the availability of treatment modalities in each hospital are very important for choosing the proper modality for subepithelial tumors. Based on originated layer of subepithelial tumor on US, I usually use one of various endoscopic resection techniques, such as endoscopy submucosal resection, ESMR, ESMR-CNL, ESD, endoscopy submucosal tunnel dissection, or endoscopy full technique resection. First is the endoscopy submucosal resection, ESMR. This technique is similar to classic EMR for GI epithelial tumors. The classic indication of this technique is when the size of subepithelial tumor less than 2 cm, polypoid cyst shape, and intraluminal growth. In the case of ESMR, I talk about this technique later, the size less than 30 mm due to limited size of ligate cap. I'll show you one case. We can see subepithelial tumor and gastric angle. This region is heterogeneous hyperechoic region. In this case, first I perform submucosal saline injection, and then I resect the tumor by using Snell directly. The tumor is completely resected. The final pathology is inflammatory pulmonary polyp. This is the ESMR technique, very simple. Next is ESMR-C and ESMR with a ligand device, ESMR-L. I usually use ESMR-L. I show you movie file. We can see subepithelial tumor with a central depression at the posterior side of duodenal bulb. This region is hypoechoic region in the second and third submucosa layers. I decided to perform ESMRL. First, I place marking by using snail, sometimes by knife, like this. And then I perform submucosal saline injection beneath the tumor. Thereafter, I attach the ligase device to tip of endoscope and then suction the tumor completely. At this time, I deployed the elastic band. Thereafter, I placed the snare not above elastic band, just below elastic band. This is a very important technique to increase complete histopathology section. Then I tighten the snare and then resect the tumor by using mixed electrosurgical current like this. The tumor is completely resected without perforation. The final histopathology is a neuroendocrine tumor. I'll show you another case. We can see subway tumor at the low esophagus. The color is yellowish like this. In this case, I also perform ESMRL. On US, this region is heterogeneous hypoechoic region in the deep mucosa layers. I resect the tumor beneath the elastic band like this. The final histopathology is a granule cell tumor. Next technique is ESD. This technique is similar to ESD technique used for GI epithelial neoplasms. I saw in movie part, we can see subep tumor with a lattice mucosa change at the great curvature side of gastric lower body. On US, this region is the unequal region, some solid component like this. The patient suffered from intermittent abdominal pain. Therefore, I decided to perform ESD. In natural flexion position, I place the marking around the tumor by using dual knife like this. Then I perform some saline injection in this position in natural flexion position. Thereafter, I start pre-cutting from this side to proximal side by dual knife like this. Thereafter, I start submucosal dissection. However, we can see too much fat in the submucosal layer. Therefore, I decided to perform traction-assisted ESD. I tied dental floss to one end of Helmut clip and then insert the endoscope again, and I placed the clip, the distal portion of a flap, and then traction was done like this. We can see easily separated submucosal layer and the muscle layer. Therefore, I continuously performing submucosal dissection. Parallel just above a muscle layer and parallel muscle layer like this, very carefully by using IT nano knife. Then we can see subepithelial tumor here. This tumor region, cyst region, I tried not to injury to peritumoral capsule. Therefore, I perform some dissection beneath the tumor capsule and the muscle layer very carefully like this. At last, the tumor is completely resected without perforation. The resect tumor size above 5 centimeters. Final histopathology is duplication cyst with some component of ectopic pancreas. I'll show you another case. We can see subep tumor at posterior side of gastric fundus. On US, this region is a heterogeneous hypoechoic region with some component of hypoechoic spot and unequal cyst region in proper muscle layer. Therefore, this region is highly suspicious of GIST. Therefore, I decided to perform ESD. First, I place peripheral marking and perform mucosa pre-cutting. During submucosal dissection, I found the tumor is covered by inner circular mass fiber. Therefore, I cut the inner circular mass fiber and expose the tumor. And then I perform some tumoral dissection like this without make perforation and without injury to peritumoral capsule like this. The tumor is completely resected. Final histopathology is low risk GIST. Next technique is endoscopy submucosal tumor dissection, ESTD technique. This technique is a modified POEM technique used for treatment of achalasia. The best indication of this technique is when a tumor is located in esophagus or gastric cardia and antrum, And the tumor is located in submucosal or proper muscle layer on US and the size less than 4 centimeter. However, when the subway tumor has definite mucosal ulceration or irregular border on US, highly suggestive sign of margin change, this technique is contraindicated. Now, I saw in movie file, we can see subway tumor at Gastrointestinal. This region is anechoic hypoechoic region in proper muscle layer. Therefore, these regions highly suspicious leiomyoma. The patient strongly need to resect. Therefore, I decided to perform endoscopic resection. First, I perform submucosal saline injection, 5 centimeter proximal the region, and then I make a mucosal hole, vertically about 1.5 centimeter by using dual light. And then I created submucosal tunnel by using dual light and the IT knife. Then we meet subepithelial tumor. I cut the peritoneal dissection. This is the mucosal side, and this is the muscle side. Especially in the case of a muscle side, subtumoral peritoneal dissection, it is as you can possible, please cut the muscle fiber not to make a perforation. Therefore, I cut the muscle fiber very carefully. Then the tumor is completely resected, and then I remove the tumor by using snare. Then I perform hemostasis and close mucosal defect by using hemoclips. Final histopathology is leiomyoma. Last technique is endoscopy peritoneal resection, EFTR, without laparoscopy assistance. There are two kinds of techniques. One is the non-exposed EFTR, and the other is exposed EFTR. First is the non-exposed EFTR with OTS clip. In Korea, OTS clip is not covered by Korean government insurance. I have no experience about endoscopic resection using OTS clip for GI subepithelial tumors. Therefore, I introduced one case report from the journal site. We can see subepithelial tumor at gastric fundus. This region is hypoechoic region in proper muscle layer. We grasped the tumor by using Anko device and pulled completely afflicted cap. At this time, we released the OTS clip like this. Then we resect the tumor by using snare just above OTS clip, not below OTS clip. This is a different technique compared with ESMR. However, this technique is very simple and very rapid technique. However, there are several limitations such as side limitation less than 50 millimeter due to limited size of afflicted cap and limited I0 resection about 76%. Therefore, I prefer to perform exposed EFTR. We can see subepithelial tumor as gastric fundus. This region is heterogeneous hypoechoic region in proper muscle layer by mini probe. Therefore, this region highly suspicious the GIST. Therefore, I decided to perform ESD, peripheral marking, and mucosal cutting and submucosal dissection. During submucosal dissection, I found the tumor is highly attached to proper muscle layer. To achieve histopathological complete resection, I decided to perform exposed EFTR. I cut the muscle fiber and the submucosal layer like this and resect the tumor completely. Thereafter, I close whole defect by using hemoclip like this. The tumor is completely resected. The final histopathology is very low risk GIST. I summarized my treatment approach for GI subepithelial tumors. This slide shows which method I choose for GI subepithelial tumors when I perform endoscopic resection. First, I check EUS. When the tumor is located in second and third layer, in other words, the mucosal and submucosal layer, I check growth pattern. Growth pattern in intraluminal growth, I usually perform ESMR. When the growth pattern is intramural, I check the side. Side less than 30 millimeter, I usually perform ESMR. When side more than 30 millimeter, I perform ESD. When the tumor is located in proper muscle layer and the side less than 4 centimeter, I check the site of tumor. Site is esophagus, I usually perform ESTD. When site is stomach, I check growth pattern. Growth pattern is the extraluminal growth. I usually transfer the patient to surgeon. When growth pattern is the intraluminal and intramural growth pattern, I check the MP connection site degree. When the MP connection degree is narrow, I perform ESD. MP connection is very wide. I sometimes perform EFTR, sometimes perform EST, especially when tumor is located either in case cardiac and case 3 antrum. This is my endoscopy approach for GI epithelial tumor during endoscopy. When I find a subway tumor during endoscopy, first I check the color. Color is translucent, yellowish or bluish. The lesion may be cyst, lipoma, or vascular lesion. When the color is normal, I check the presence or absence of surface erosion and ulceration. Surface erosion and ulceration presence, I perform endoscopy post biopsy. When the surface erosion and ulceration is absent, I check Cushing sign by using endoscopy forceps. When Cushing sign is positive, the lesion may be cyst or lipoma or some kind of ectopic pancreas. When Cushing sign is absent, I check the rolling intent sign. When rolling intent sign is both negative, I perform endoscopy post biopsy by using Byeon bite technique 30 or 4 times. When rolling intent sign is present, I check the size. Size less than 1 centimeter, I usually recommend endoscopy observation 6 or 12 months later. When size more than 1 centimeter, I recommend EUS. Especially the tumor is located in peripheral mass layer. When size less than 2 centimeter, I usually recommend observation. When size more than 4 centimeter, I turn the patient to surgeon. When size between 2 and 4 centimeter, I choose one of use FMB and resection, observation, sometimes operation. In conclusion, subway tumors are commonly found during upper GI endoscopy, about 30%. However, it is not so easy to decide whether to resect subway tumor or not. Decision for resected subway tumors depend on present symptoms, degree of malign potential, and the patient's and endoscopy aspect. Knowledge and experience is very important for treating GI subepithelial tumors. Thank you for your kind attention.
Okay, thank you, Gwang Ha and Antonio, for your interesting, informative talks. So now we are discussion time. So do you have any question, Helmut?
Yeah, I think we start with a Q&A from our participants.
Audience?
There are two. Please use a Q&A. There are two questions in the Q&A, and the first is, increasing size during follow-up is important for further management. What is the size increase ratio or definite increase in number of millimeter, and how much is that?
May I reply?
Yeah, Antonio.
I think it's more about my presentation. Okay,
Yeah.
It's not always easy to. Okay, we know that, like many aspects of endoscopic ultrasound, also size measurement is operator dependent. So finding the exact number of millimeter, of course, it's not really objective. What I do, okay, the cutoff that we have usually is 2 centimeters, more than 2 centimeters, less than 2 centimeters. So if we have a lesion more than 2 centimeters, we already see that usually it's indication to treatment. When it's lower than 2 centimeters, we keep in follow-up in absence of a stigmata. Once it goes over beyond 2 centimeters, we consider the resection or the surgery. This is what we do, but we don't have perfect studying this thing, okay? So it's just about the opinion, personal opinion.
Can I answer too? Yeah. In my experience, yeah, it is very difficult to measure the size of subway tumor during endoscopy. As you know, according to the air inflation and the movement of GI mucosa, the size of subway tumor somewhat changes. Therefore, usually when the size of subway tumor increased more than 10%, I think this tumor is really increased. Therefore, according to another previous Japanese study data, when the increase of size is more than 2 millimeters in every year, maybe the potential of malignancy is increased. Therefore, I usually recommend when the size is more than the increase in size more than 2 millimeters every year, I think this is a possibility might change. Therefore, I recommend endoscopy or surgical resection when the tumor size is less than 2 centimeters. this is my personal experience.
So, Gwang Ha, that means if a subepithelial tumor of 1 centimeter or so increases up to 1.4 centimeter in 1 year, then you recommend surgery, even though it is far smaller than 2 centimeter.
Yeah, more less than 2 centimeters, I usually recommend endoscopic resection rather than surgery. Yeah, because when the size is less than 2 centimeters, it is very difficult to resect the tumor by surgery. Of course, recently, single-port laparoscopy surgery for GI subabdominal is possible in Korea and Japan. However, even in expert surgery, it is very difficult to find small subabdominals. Therefore, when I transfer the patient to surgeon, the size more than 2 centimeters or extraluminal growth pattern. It means surgeon easily find the subtumor during surgery. When the size is very small, there is some need to resect the tumor. In this case, we endoscopist visit the surgical room and we find the subtumor and the marking, and then resect the tumor with a laparoscopy.
So we have many questions now coming in, which is good. Maybe perhaps we start from the top. One question is on the Cushing test, how to perform the Cushing test. Maybe it's a question, Professor Kim, you showed this in the presentation.
Yeah. You imagine the balloon. In the case of balloon with water, we can press the balloon. Balloon is easily transformable. The same is easily compressible. Therefore, we press the subabdominal by using endoscope biopsy slightly. The region is easily then we call question sign positive. Therefore, question sign positive means the tumor have some kind of liquid, lipid, or air component.
Liquid or air or fat.
Yeah,
so
fat.
Lipoma,
Lipid.
lipoma is also showing positive question sign.
The next question is very interesting because this is always a matter of discussion in Germany. When and how to resect, when have we to resect ectopic pancreas? So how is the approach in Korea and maybe in Italy? Do we need to resect heterotopic pancreas in the antrum if it's clear?
Antonio, first, for me, first, yeah.
Maybe both. Antonio first then.
Okay.
Antonio, how do you approach?
Okay, of course it depends. If we have no symptoms, small lesions, not in this case, no. So it depends on the situation. There is not an univocal indication for ectopic pancreas. In my experience, for example, several cases, very mild cases, no particular symptoms, no problem. So in this case, we may be less.
To my knowledge, in the literature, there were only a couple of cases published where a cancer developed in this heterotopic pancreas. Maybe the risk is the same as in a normal pancreas where you
yes,
cancer. So then you should resect each pancreas to avoid pancreatic cancer. So this is not an argument for me to resect. I also make it individually. There are young patients, very anxious. They don't know what it is, and they really force you to resect. I'm not sure how it's in Asia. How do you proceed with this kind of lesions?
Yeah, I published about ES finding about ectopic pancreas. There are two kinds of ectopic pancreas ES type. One is superficial type, and superficial type means the ectopic pancreas is located second, third, submucosal layer, and the deep type is the tumor is located third, fourth, and fifth layer. In the case of a superficial type, it is possible to resect the tumor, subtumor by endoscopy very easily. As the Professor Helmut talked about, the younger patients stronger lead to the resected tumor, I perform ESD. However, deep type of ectopic pancreas is very, very difficult to resect the ectopic pancreas by endoscopy alone. Therefore, in this case, I do not recommend endoscopic resection. When the patient suffers from intermittent abdominal pain, some kind of cirrhosis change in the ectopic pancreas, or during the US, there is some kind of cystic region and solid portion on the cystic dilation duct. At this time, we must consider the panning like dysplasia change in ectopic pancreas. Sometimes at this time I transfer the patient to surgeon. However, it is very, very rare to resect the ectopic pancreas in Korea.
So is it right that basically we don't need to try resection if we are confident that subepithelial tumor is gastric ectopic pancreas without symptom?
Yeah, perfect.
The only case we consider resection is the strong desire of patients, right?
Or
for some cases
symptomatic.
Some symptomatic cases, or some ectopic pancreas cases with somewhat uncertainty about the diagnosis.
You're right. Yeah.
There's one question about pediatric practice. So is there a difference in children compared to adults in making surveillance, diagnosis, treatment? What is your recommendation, Antonio?
No, it depends on the lesion, of course, of the disease. Not particular difference, of course. In the case of pediatric, okay, the resection, we should be more careful about that, of course, but it depends on the lesion, the disease we are talking about, not much about the age.
Yeah, okay.
I have no experience about pediatric practice. Yeah.
Okay. Another question. Jeong, would you continue with question, or can I? There is the question about closing defects after ESD or CAP EMR if the lesion is 1.5 centimeter or larger. It's necessary.
Yeah. In Korea, we usually do not close the mucosa defect after ESD for even the size more than 5 or 6 centimeters. However, in high risk group with patients such as taking the NSAID or NOAC, we sometimes close the mucosa defect to decrease the incidence of delayed bleeding. With case by case, we generally do not close the mucosa defect.
Okay, actually, I'm very interested in this question. So do we all agree that a biopsy should be done before any resection in order to avoid unneeded therapies?
Okay, I read the question, my friend Thomas Togliani. Yes, I agree with it.
I thought it's an Italian expert.
Yes,
yeah?
no, I was reading that,
Yeah.
that question. Yes, I was very interested. Yes, absolutely, I agree. Just, okay, if you are sure that you should resect that lesion because ulceration, these things, that you have expertise in advanced resection technique, maybe you can do the approach, okay, both diagnostic and resection using advanced resection technique. But in my experience, I agree that FNB, or at least just endoscopic ultrasound, should be morphologic endoscopic ultrasound should be attempted to get a diagnosis before the therapy. I agree.
How about Gwang Ha? You are a more therapeutic endoscopist.
Yeah.
So
yeah.
do you agree in this question, or do you sometimes perform endoscopy resection without prior biopsy trial?
Yeah. If I can the tumor completely, I do not perform endoscopic biopsy before endoscopic resection because I can completely resect the tumor. However, in the case of GIST, when size more than 4 or 5 centimeters, from my experience, the accuracy of EUS for GIST different GIST from non-GIST tumors around 70 and 80%. At this time, I confident this tumor highly suspicious. I do not perform EUS FNB. I transfer patient to surgeon or to I perform endoscopic resection directly without tissue confirmation.
Mm-hmm. And one question, although is on the growing from 5 to 15 millimeter, is this an indication for resection without any taking biopsy? If you have a very a fast-growing tumor, should we resect immediately?
I will try to get a biopsy, of course.
Okay.
Okay, because it's a safe technique, it's not a problem, but this is what I will do.
And another question to
Gwang Ha?
Dr. Kim. Yeah, sorry.
Yeah. Also, if I can resect the tumor directly, I perform endoscopic resection. And the ES find is highly suspicious of cyst, and the tumor is showing extraluminal growth. I sometimes transfer the patient to surgeon directly. In other case, I also perform endoscopic post-biopsy.
And another question is, Dr. Kim, can EMR be done after placement of the scope clip and then performing polypectomy over the OTSC clip? For example, padlock clip. But I think this question is more suitable to Antonio, because
Antonio,
OTSC is not widely used in Korea. So we have very, very little experience about OTSC.
Yes. Of course, I read also another question, not very similar, but everything that you can do before resection may complicate resection later. One colleague asked also the biopsy. If you do biopsy before resection may complicate. We don't have clear studies about that, so it depends also about the experience of it. My personal opinion, experience, I don't think it's a big deal, but of course I would like also to get the other opinion of other members of the panel.
The problem, a very important topic or problem are subepithelial tumors in the duodenum. How to approach? Is there a difference to a stomach or esophagus? So, I mean, in Europe we use this over the scope clip. I think we have experience from the colon, where it has been first used, and now more and more we have experience with upper GI. The full thickness resection is not always possible in the stomach, but it's possible in the duodenum. But the duodenum, my experience is sometimes not feasible because of the location, or it sometimes also could be dangerous. What is your experience, Antonio, with OTSC in the duodenum?
No, I agree. No. It's, you need a very huge expertise in that. There is some risk. So yes, you should be very, very careful. And also about the question, the decision about duodenum, as I told you before, the risk of malignancy is quite higher in the duodenum as compared to stomach. So in this case, the decision for resection, for example, surgical or endoscopic, depends on the expertise, should be more careful and more likely in this case.
Okay. And is FNB, does this affect ESD or endoscopic resection? Question to both.
No, there is no data about that. No. I would say no. We don't have data, in particular for FMB. No.
Yeah. Professor Kim, do you think it's disturbing if you take a fine needle biopsy and then later on you resect the GIST by a tunneling technique? Is there a scarring issue?
Yeah, and I told you before, when the GIST is highly susceptible on US, I perform ESD directly without obtaining a tissue biopsy. But when I transfer to surgeon, I sometimes perform ESFMB. More, it looks, I cannot differentiate this region, the rhizomyoma, C101 GIST. I sometimes perform ESFMB. However, when I perform ESD, I do not perform ESFMB before. This is my policy.
I don't know. There is some good data about this issue, but I think it may not. ESFMB may not be leading to significant difficulty in ESD, because EUSFMB is approaching the top from the top of the tumor, but ESD is usually done beneath the tumor. So I don't think fibrosis may be formed at the beneath of the tumor. So I think ESFMB does not affect, would not affect the difficulty of, yeah.
I would be cautious with the bite-in-bite technique.
Yeah.
And then after that, a stair procedure that can cause more fibrosis. But I agree, FNB is probably not an issue.
Yeah. In the case of surgical resection, some surgeons complained about the fibrotic change and hemorrhage change pro-GI epithelial tumor after ESFMB. Therefore, so surgeons sometimes recommend please do not perform ESFMB in the case of surgical resection.
Okay. There are still a lot of questions. I think perhaps it makes sense to come to an end, and our experts can answer the questions online. Perhaps we pick up two last questions. My interesting question is about elastography in endoscopic ultrasound. Quick answer, Antonio.
Yes, I showed you the slide. We don't have much data about, we use for pancreatic masses, also because it was demonstrated, you know, pancreatic cancer is heterogeneous. We have necrotic areas, so it may guide the puncture also in the most vital area of the tumor. For subepithelial lesions, usually I don't use it, honestly, because, okay, if I need a diagnosis, I do the biopsy. I don't think it may be very, very useful in this setting, but okay, we need data. We don't have data about it. We have very few data about it. I think it's more useful for pancreatic masses. This is my opinion in endoscopic ultrasound.
Yeah. For me, I sometimes use elastography. However, in the case of elastography, the subjectivity is very important. Therefore, the current elastography not so useful for differential GI survey tumors for me. However, in the future, shear wave elastography is very somewhat accurate, expressed in the number data. Therefore, shear wave elastography will be beneficial in differentiating GI survey tumor in the future. I have no experience about shear wave elastography. Yeah.
Okay. I'd like to ask the last question.
Last question.
So frequently, GIST has characteristic vascular pattern. I think abundant vascularity. So do we really have to puncture before resection?
Yes. Response. Yes, because they cannot replace, the vascularization cannot replace, I show in the slide, tissue acquisition if we need to resect. So if we need to resect, I think there are some characteristics. So we should get a diagnosis, histological diagnosis. So yes.
Okay.
For me, case
How
by
about
case.
case? Okay, well, continue.
Case by case. Yeah. For me, I already talked about that.
Okay. Then I think we should stop here because many in Europe, because of the time difference, we are still busy, and our friends in Korea hopefully can now enjoy the evening, the rest of the day. From my point of view, would like to thank you really for this wonderful webinar. It was a pleasure. It was one of the best webinars, and would be happy to continue with KSGE. Have to announce some dates for our participants. So as said, ESGE plans ESG days next year, and for this Congress, please, the application for ESG research grants is now open, and the deadline is the 15th of November. So this is one important date. And then regarding our Congress next year in spring, abstract submission is also an important point, and here the deadline is also in November. So please take care and submit your abstracts in time. And then the highlight for ESGE is our Congress, our Jubilee Congress next year. We celebrate 60 years of ESGE, and we welcome you next year in Berlin, and we expect about 5,000 participants, and we really would be happy to have many people from Korea. And the definite highlight, maybe, Byeon, it's your announcement.
Okay, so I was also very happy, and it was really wonderful webinar today. And the Korean speaker, Professor Gwang Ha Kim, and Korean audiences also must have had a very, very interesting and fruitful time today. And I also hope this joint event will continue and progress forward. And I would like to show the event which will be held in Korea. It is ENDO 2024, which is organized by WEO, World Endoscopy Organization, and Korean Society of GI Endoscopy and IDEN together. And it will be held July 4 to 6, 2024 in Seoul, Korea. And now the submission is open, so please be interested in this event and submit your study abstracts. And I hope we can meet together face-to-face in Seoul next year.
Absolutely, happy to join. Okay, but this is now the last slide regarding our webinar series from ESGE. Next will be in the 22nd of November, an important topic, ampullary lesions management, with great speakers. So join us next time. It's in the evening. There is our friends in Korea, that's midnight at that time. I don't expect too many participants from Korea, but you're actually always welcome to participate in our webinars. So thank you again. Enjoy the rest of the day to everybody. Thank you for joining the webinar. Thank you to the speakers, and Jeong, thank you for moderating with me. This is great webinar. Thank you.
Okay, thank you.
Thank you.
Thank you.
Bye.
Bye-bye.